So what you find in many cases, if patients are not doing well or still having seizures, physicians add to their drug regimen. So if you're on one ASM and you're still having seizures, they add a second ASM or a third ASM, anti-seizure medication as it goes. And that is a very accepted approach, especially if people keep having seizures. But what also has to be done, and this is why we went back and looked at the data, is the reduction of the other drugs. So let's say the reduction of the older drug. And because otherwise, if you just keep adding and you just keep adding, the chances are you're going to wind up with more side effects. And what happens when patients wind up with more side effects? They stop using, they'll they'll either stop using the drug, or what's the typical reaction is, I didn't have these side effects until you added this drug, so now it's that drug's fault. When in reality, it's not. It's basically the combination of two or three or more different drugs that you're taking. So when we went and looked at the data, we found that as the physicians became more comfortable with the utilization of the drug, and in this case, it was cenobamate that they were using, that as they became more comfortable, they were more aggressive as time went on in reducing the concomitant medications, the medications that the patients were already on. And that is a very good approach, because then what you're also doing is you're limiting the side effects. And then the other thing you're doing is, and again, this is in general, we're talking in general in epilepsy, you're giving the new drug a chance to work. Because what's happened, obviously, if you're being put on other drugs, your older drug was not working, or it wasn't working well enough. Hence the reason they're adding a new drug. So what you don't want to do, and again, this is just in general, you don't necessarily want to blame the new drug that, oh, I'm having this side effect, I'm feeling dizzy, or I'm very sleepy or something like that. And so what the knee-jerk reaction is, I'll remove the newest drug I just put on board, when that's not the right thing to do. What you should look to is to reduce the drugs that were not effective. But of course, many people will say, well, they weren't having this problem until I added drug X. So now I'm just going to remove drug X. But then what happens when you do that? Well, you're back to square one. And so no one's benefited at all. And the idea is that you want to give patients the best chance to get to the right levels and the right dose of the new medication, and potentially get them to seizure freedom. But you can't do that if you don't give the new drug the opportunity to get to the level that they need to get to. And so that's what we found. And if you look at the study, you'll see as time went on, they started dropping the doses of the other drugs. And we see this now too, as people become more familiar or they become more comfortable, they feel more comfortable in dropping the other medications. And that doesn't mean, I want to be very clear about it, that doesn't mean they discontinued the other medications, because sometimes that's not the right thing to do either. But what was important is that you drop the dosage of the other drugs, because, in many cases, you need a combination of drugs to control seizures. So you're not always going to just say, we're going to put on, you're only going to be on this one drug. That would be unrealistic to think that. That's not the case. Yeah, so, well, the limitations in the data that we looked at was, this was what was called open label. So basically, what that means is that this is not a randomized situation. This was basically, physicians had the opportunity to more or less do whatever they wanted to. Um, and when you do an open label, if you would, trial, there's no comparator, if you would. Okay, there's no placebo arm and there's no comparator. That doesn't mean that the data is not important. That doesn't mean that the data should be discounted, because many studies are done open label, especially after drugs are approved and on the market a while and such. But yes, that was the limitation, because it was not a randomized, double-blind control trial. It was basically an open label. So, and the other thing is, when you do open label, that means everybody knows what you're taking. When you do randomized trials, you don't know what the patient's taking. So those are the limitations of the trial. But again, once the drugs are on the market, that's not unusual that you do open label trials, if you would. So that would be the basic limitation of the study that we looked at.